I'm Dr.
Sir,
Kriplani VH, practicing from last 36 in Kolhapur, Maharashtra, and I've been associated with Public Health Foundation of India from last 12 years, conducting their sessions, and presently I'm working at Kriplani Hospital, Tarawih Park, Kolhapur.
how does Imeglimin fit into your regular practice with the current landscape of T2DM treatment options? Kindly share your experience.
In fact, this molecule was introduced in India market way back in 2022, and it was approved for management of type 2 diabetes in Japan in June 2021. Initially, we felt that this is a desperate molecule. In the sense, when nothing works and the patient is not willing for insulins, we thought, okay, we give a trial with Imeglimin. And to our surprise, it did wonders. The blood sugar levels were well under control, HbA1c was to the target, and we required to reduce the dose of sulfonylureas, including the dose of insulins. So we had more faith in this molecule when we just started practicing with this molecule. This molecule, interesting part, is the only anti-diabetic drug, oral hypoglycemic agent, which acts both at insulin resistance and insulin sensitivity by a mitochondrial pathway. The mechanism of secretion of insulin at the beta cells is something like the natural pathway, that is a glucokinase pathway, and it does not increases insulin secretion unlike sulfonylureas, and therefore it has a beta cell preservative effect. Similarly, it also acts on insulin resistance. It improves insulin sensitivity, reduces the glucose uptake, hepatic glucose output, and increases the glucose uptake at the muscle level. So this is only anti-diabetic drug which is available as on today, which has a dual mechanism of action. It improves upon insulin sensitivity. Simultaneously, it increases the insulin secretion in glucose-dependent manner. So risk of hypoglycemia is minimal, no weight gain, and it is better tolerable.
In what specific patient population do you see the greatest benefit of using Imeglimin?
Now, this is a Japanese molecule. As of now, it's not approved by ESD or ADA, and in fact, you can prescribe at any stage of management of diabetes as a monotherapy or along with other oral hypoglycemic agents. When given as monotherapy, the mean change in the HbA1c from the baseline is around 0.87%, which is comparable to any other oral hypoglycemic agents. The effect is more profound when you co-prescribe with the DPP-4 inhibitors compared to other oral hypoglycemic agents. However, the molecule is compatible, can be given with all available oral hypoglycemic agents, including insulins. And as I said, the efficacy seems to be more profound when co-prescribed with DPP-4 inhibitors.
How does Imeglimin compare to other hypoglycemic agents in terms of safety and efficacy? Kindly share any real-world case if you have.
See, as I said, it reduces HbA1c as given as monotherapy by 0.87% from the baseline one. So it's a good anti-diabetic drug. It is better tolerated compared to metformin so far as GI side effects are concerned. Now we have sustained release preparation, which reduces the GI-related side effects by another 50%. It does not produce hypoglycemia. It does not produce weight gain, and therefore it's justified to treat this patient. Maybe in times to come, when more data is available, maybe it may be declared as a gold standard in management of type 2 diabetes, as metformin, which was endorsed by US FDA way back in 2005.
In recent time, Imeglimin sustained release formulation with Indian study has been launched in India. What is your opinion on that?
Now, there's a very small percentage of patients would have GI side effects in form of nausea, vomiting, loose motions, abdominal discomfort. With sustained release preparation, the side effects related to Imeglimin, immediate acting, are controlled by more than 50%. So more than 50% of the patient would tolerate Imeglimin in a better way compared to the immediate release preparation.
How does the mitochondrial targeting mechanism of Imeglimin influence its clinical use?
Now, basically, it acts intracellularly. It acts by an alternative pathway, not by glucose and glucokinase pathway, but it acts in a glucose-dependent manner. At beta cell levels, it enhances endogenous insulin secretion without risk of hypoglycemia. It has a beta cell preservative effect. At muscle levels, it enhances the uptake of glucose from the blood, and it improves the utilization of glucose at the muscle level. It reduces or suppresses gluconeogenesis, and therefore it reduces the hepatic glucose output. So in both the ways, both at the muscle level, the liver level, and the pancreas level, it improves the sensitivity, so also endogenous insulin secretion, and thereby helping control the blood sugar levels.
What are the key safety and efficacy findings from clinical evidences on Imeglimin that clinicians should be aware of?
See, you cannot give Imeglimin if the EGFR is less than 45, rather less than 45. You can very well give if the EGFR is more than 45. One. Secondly, it can be given in a mild degree of hepatic impairment, cannot be given in patients with severe degree of hepatic or moderate to severe degree of hepatic impairment. It cannot be given in pregnancy or lactating mothers. So no data is available so far the molecule in pregnancy or in lactating mother. So otherwise, you can prescribe in any patient with type 2 diabetes at any level, if as a monotherapy or in combinations with other oral hypoglycemic agents, including insulins, with a better safety. And in clinical practice, you definitely see that doses of sulfonylurea can be reduced significantly. So also the doses of insulin also can be reduced significantly.
Do you believe that Imeglimin has the potential to change the future landscape of diabetes treatment?
Yeah, in fact, as I said, in 2005, metformin was declared as a gold standard in management of type 2 diabetes by ADA. Now more data is required to approve this molecule as a gold standard in management of type 2 diabetes. Maybe in future, it might replace the use of metformin. And since we have immediate release, sustained release preparation, like metformin sustained release preparation, the GI side effects are much less. It's better tolerable, and it has a dual mechanism of action. It does not produce hypoglycemia. There's no risk of weight gain. It can be given with any other oral hypoglycemic agents. The effect seems to be more pronounced with the DPP-4 inhibitors. It also helps in reducing the doses of insulin when co-prescribed with Imeglimin. So definitely, the drug seems to have a better future, like any other oral hypoglycemic agents, including metformin.
Any other key points or take-home message you would like to share apart from this?
Now, since this is a Japanese molecule, the data available about Imeglimin is very limited. Now we'll be having more Indian data about the use of Imeglimin in future, and therefore we have more ease of prescribing this molecule in most of the patients with type 2 diabetes, diabetic patient. As I said, one has to take into consider the renal aspect, the kidney aspect, the hepatic aspect, the pregnancy. Otherwise, you can prescribe these molecules to all of your type 2 diabetes patients.